It is a huge, huge honor for me that Tif Qureshi took the time out of his schedule, and it's so amazing, the internet. I'm in Phoenix, Arizona. It's 10:30 in the morning on a Wednesday, and it's 6:30 p.m. in London. And dude, you have been a pioneer and crushing it your entire career. I'm a huge fan of your 600 plus posts on Dental Town, your online CE course. I mean, you have just been nothing but innovation your entire life. So I want to start. God, I mean, you're a past president of the British Academy of Cosmetic Dentistry. You sit on the editorial board of Dental Update. But you, I would say that the first time I heard about you is when you were pioneering the Inman Aligner. So first of all, great to meet you. Tell everybody over here in America about yourself and the and how did you get interested in the Inman Aligner?
You can hear my dog. Apologies.
The dog just said he loves it. I can speak dog.
Okay, as I say, I'm from the UK, and back in 2003, 2004, when we were doing a lot of veneers and stuff, I was always at a different way of restoring teeth, and I was using bonding and all this as well. But I wrote an aligner in the AACD journal, and also an orthodontic journal as well. And I thought this is quite an interesting thing. So I contacted Don Inman, some cases to him, and I was just amazed. In fact, the kind of cases that I was doing, Don didn't think work, push the boundaries a little bit, and we develop all the protocols. And I think probably not being an orthodontist just gave me a slightly different perspective on how we could use it. We were looking at things in a very analytical way, and millimeter measurements and the whole dynamics of it. And we started to realize what it could do, what it couldn't do. Eventually, a couple of years later, I kind of revealed it to a lot of my colleagues at the BACD. And for many of them, a lot of them are still were prepping a lot of veneers at the time. I think it was quite a jaw-dropping moment to see what I was doing with this little appliance. And so from there, this course just started almost like a bit of a hobby and a joke, really. And eventually it's grown into what it has. So that's pretty much where it's come from.
So the Inman Aligner was named after Don Inman. And he's an orthodontist?
No, Don Inman is a technician in Coral Springs in Florida, and he is a very humble guy, an American who actually I call one of the unsung heroes of cosmetic dentistry, and people need to know who he is and know his name because he invented the Inman Aligner. And, I just took the aligner and I developed it and made it work in situations that he didn't realize it would work. So
now, does he still work in a lab? Does he still make
definitely.
Inman Aligners?
He builds most of the Inman Aligners in the USA. There's only several labs that are commissioned to do it, and Don's lab probably builds most of them.
So will you send him an invite after this one, and we'll follow your podcast with one from him?
I think that would be a great idea, because you'll hear his side of the story, and you'll hear how a technician's kind of has been involved in the whole process, and Don's really helped, especially with the whole digital workflow and our interpretation of digital workflow. And actually, I would argue that the stuff that Don and I have been doing with digital interpretations has been leading the way in aesthetic orthodontics.
Before you get into that, I want to stop you. I'm trying to guesstimate. On our first 75 podcasts, we went over 100,000 views. Most people listen to these on sound only in their car while they're on a treadmill or driving to work, whatever. And I always trying to guess their question. The first question everybody's going to have is, what the heck is an Inman Aligner?
What is it? It's a removable appliance which is designed to straighten the front 6 teeth. It's driven by nickel titanium coil springs. It works within a very restricted area, so it's extremely safe and very predictable, so you know where the teeth are going. And it doesn't work for every patient. It's not going to work for every case. It's not a comprehensive treatment in any way. But in cosmetic dentistry, for those kind of cases where you have that slight anterior misalignment, it works like magic. It works quickly, effectively, and patients patients love it. Simple as that, and it's made a huge difference the world, really.
And you're okay, now what is the IASortho.com? What is IAS?
What is IAS?
Ortho.com.
IAS
Intelligent
means
Alignment System Academy.
Intelligent Alignment Systems. That's correct. Now, in the UK, we have, obviously there's a lot of ortho in the US, but in the UK, our market has, I'm not saying it's more mature. I think the number of dentists per head doing ortho, general dentists doing ortho, I think is higher. So we've really gone very quick, a long way, very, very quickly. And as a result, there's a lot of systems out there pushing appliances, pushing buy 5 cases, get 3 free kind of thing. And what we're trying to do with IAS Academy is to provide an ethical, staged learning approach for dentists. So we're not going to drop dentists into full mouth fixed ortho. And it's also very much about teaching the dentist what they're doing. It's fundamentally based on diagnosis and a correct assessment. So you can't just take an impression, throw it to the lab and expect a lab just to do everything for you. Of course they can, but medical legally, you're going to be in deep trouble if your case gets picked up and all it says is, I took an impression and sent it to the lab. The dentists need to be in control of these cases and understand why they're doing what they're doing. So the whole basis of IAS Ortho is to actually provide that pathway of learning.
So he's saying IASortho.com for Intelligent Alignment Systems Academy. And so if this lady's driving to work right now, and if she goes to that website, what's going to be on there? Do you have online courses that teach how to diagnose and treatment plan ortho?
Yeah, that's absolutely correct. There's several. Does
it cost money to join this site, or does the city cost money, or what? How does this work?
Yes, also, the Inman Aligner is often considered the first place most dentists will look when they're getting involved in ortho, because it's such a simple, safe technique. Not a lot can go wrong. So Inman Aligner is part of IAS, and then there's also clear aligners, and there's also fixed braces. And also, there's actually a very high-level advanced course that's been run by a professor of orthodontics in the UK. So,
what's his name?
His name is Professor Ross Hobson, and he's one of the leading orthodontists in the UK.
So, can you deliver him to me on a podcast?
I think we definitely can.
Right on. This podcast has already turned into 3.
I know.
I'm hitting the bullseye this morning.
Ross is a crazy guy, and he's an accomplished sailor and a petrol head as well. So I'm sure he'll be an entertaining speaker.
What's his name, Ross?
Ross Hobson.
Hobson?
Yes, Hobson.
And he's an orthodontist?
He's a specialist consultant orthodontist, yeah.
And he's a sailor?
And he's a huge sailor.
And it was a British sailor that made the first medicine on Earth who discovered that if you had a Lyme, you wouldn't get scurvy. He noticed the British Navy came back and every time the British Navy came back, about a quarter of the sailors were really dying from scurvy. And he noticed one time that one boat came back and nobody had scurvy on it, and he absolutely knew something happened.
Yeah, that's correct.
And he wrote down every detail of the ship, and it took him like a month at looking at the list, and he couldn't find it. And finally he said to himself, I can't find it. The only thing different between this ship and all the others was one barrel of limes. and he had to think about that too. And that should be $100 million blockbuster movie, and you should play the British sailor. No, we'll get Ross Hobson to play the British sailor. But yeah, and the British Navy still calls them limeys to this day, don't they?
That's absolutely right. Limeys.
So let me. I'm trying to estimate questions these people are driving. So if I go to your website, iasortho.com, I can learn how to start with Inman aligners, go to clear. What do you call it? Clear what?
They'd be clear smile aligners. So they're basically like clear aligners, but they use the protocols of planning Inman Aligner uses, meaning we have digital arch evaluation.
And then you go to advanced ortho with Ross Hobson?
Yeah, well, then the next step would be simple anterior fixed ortho, just in the anterior front teeth with sectional digitally planned fixed. And then beyond that, for those dentists who want to go further to a level of comprehensive ortho, then it's a completely non-system based course where Ross will teach you a level of ortho which is close to that of being an orthodontist. That's a 1.5-year course, so it's a big commitment.
And how much? What would the pricing? How many hours and what's the pricing for like learning the Inman Aligner versus the clear aligners versus anterior?
Yeah, sure. I mean, Inman Aligner itself is a day course, but it's actually a continuum, because to be certified now and to maintain your certification, you need to actually submit 2 cases online, and that we actually assess and we evaluate. We're looking to increase the quality assurance. That's one reason why Ross got involved. But he only got involved to make sure that the quality assurance was there. So with Inman Aligner, you've got to submit 2 cases online. So in truth, the course probably takes about 6 months, because we follow your cases right from the beginning till they complete. So Inman Aligner courses in the US probably around about $800-900, and then all the online support is free. The clear aligner course that comes with that is free for Inman Aligner users. The fixed brace course is probably the equivalent of around about $1,500. And again, very similar. It's a continuum of education. It's not just a 2-day course. You actually get your hand held right through the whole process.
So I'm clear aligners. Is this would a similar brand be Invisalign? Is that kind of similar, or is this a very different? Or is this a different process?
It's different in that it's very much dentist-led. So we have something very unique that starts with Inman Aligner, a piece of software called SpaceWise. And SpaceWise is basically... My dog. SpaceWise is basically...
We love dogs.
a digital arch evaluation software. And the idea of this software is that the dentist can A, work out if a case is suitable, and B, the dentist can actually then provide the lab with an occlusal trace to tell the lab where the teeth need to go. Now, this is actually very important because it's starting to become quite a valuable part of your medical legal consent. So a lot of doctors have this now, and they can show that they had a plan from the start, not just to say, I took an impression and sent it to the lab. So SpaceWise works all the way through all of our systems, through Inman Aligner, clear smile aligners, and also through the clear braces, the fixed braces as well. And so once doctors understand how to use it, it's very, very useful to software. Okay,
Tif, how many countries are on this website? I mean, how many countries have you worked with general dentists from around the world? I mean, is this a handful of countries, or is this an international phenomenon?
It's definitely international. I think we've probably given courses in about probably 20 countries at least, I would say. Probably more than that, actually. Europe, Australia, the Middle East, say. So we get invited to go to lots of places, but we can only really go where we know it's going to work. So it is international, a large international group of lead dentists, all who are trainers and becoming trainers in these systems. And the great thing about all these people are that these are all people that came along onto my Inman Aligner course and enjoyed it, and became great at it and learned how to teach. And so we've got some great people involved in the whole, and some very talented people involved in the whole process.
So yeah. Are you mostly teaching on the other side of the pond, or are you yourself lecturing much in the United States? And how's the United States been as a part of your business? I mean, has that been a significant part of it?
Definitely. I mean, we've done a lot of training in the USA. Myself and one of my business partners, James Russell, we've probably done maybe 15 to 20 courses in the US, and I've been over there 9 or 10 times, I think, over the last few years. We're putting our course into a newer version of our course into a more online version to make it more accessible in the US. But equally, we're currently talking to a couple of trainers now over there to take over and to run the courses, because you can imagine it's difficult traveling all the time. At one point I was flying away virtually every weekend, and I don't want to get divorced or lose my children. So I'm going to make sure that I reduce the amount of flying I do. So yeah, we are planning with Don to launch more hands-on courses in the US very soon, and we hope. And we're pretty sure that Dr. Ross Nash is actually going to be running these courses with us. He's already a big Inman Aligner user, and in fact one of the biggest in the US. So that's what we're hoping to happen very soon.
Ross Nash is he North Carolina or South?
Yeah, Ross Nash, North Carolina. That's correct.
Yeah, I love his wife, Deborah Englehart Nash. I mean, what a lovely lady. I love Ross. Have you noticed that all the great American dentists are all short, fat, and bald like me and Ross? Have you noticed that? I think if you shaved your head, you would just do better in America. They'd say, "Oh, you look like Howard and Ross Nash," and then you need to gain about 50 pounds of weight. So now the clear aligners. What would be if a dentist is sitting there thinking, should I learn clear aligners or Invisalign? What would you say to that question? Is there a difference in cost?
I think it's
because when a lot of dentists think about Invisalign, they're usually thinking about $1,000 lab bill. Is that about right, or is that wrong? Or
no, I mean there's no doubt that the laboratory fees for Clear Smile are not as expensive. But you know what we're doing?
How much less expensive? 10%, 20%, half? I mean,
I would say more than 50%. Yeah, more than 50%. I mean, I can only talk about the UK here, and comparatively, but then equally, Clear Smile, we are focusing on the anterior region. We are not allowing general dentists to do full mouth ortho under a technician's prescription, and that's if that's the way Invisalign operates, that's perfectly okay with me. Our protocols are to make sure that the dentists are doing appropriate treatment that's appropriate to their skill level, and that they are responsible for the treatment. So we won't be moving molar teeth with a Clear Smile aligners. That, in our opinion, is something that either an orthodontist should do or a very well-trained general dentist. General dentists, there's enough work in the anterior region, especially if you understand the concept of RM little studies, that actually general dentists can deal with anterior teeth, maybe molars, and that's pretty much all you need. So our system, Clear Smile on it, is different. It's very much dentist-led in the assessment, but also we have dentists actually giving you online assistance as well, not lab technicians or anything like that.
So my model for me was, it was in 1998. I'd come home from work, and it was so professionally lonely when you had questions and thoughts. And I saw the internet as a thing that I could talk to other dentists like you. And how interesting this is. Now it's 2015, and I'm talking and seeing a great dentist from the UK. I mean, this is just so damn cool. But so our motto was with dentaltown.com, no dentist would ever have to practice solo again. So I'm always trying to predict, what is this individual solo dentist? What is she thinking when she's driving to work? And I think one of the questions maybe several hundred are going to be thinking is, I'm seeing this Inman Aligner, clear aligner course, and everybody's heard of Inman Aligner. In fact, when I was telling my friends that I was doing this interview with you, last night at the bar, 3 dentists said, I've heard of Inman Aligner, but what is it? And they're also hearing Power Prox 6-month braces with Rick DePaul. They're also hearing 6-month smiles, which is started by a townie, Ryan Swain, but he sold it off. So this individual dentist, what's the difference between these 3 systems, and why should I learn Inman Aligners and clear aligners versus like 6-month smiles or Power Prox 6-month braces? You know what I mean? What would be the unique selling proposition? Because this dentist in the car doesn't know anything about all 3. We just hear these brand names all the time.
Yeah, I totally get what you're saying. I think there's a slightly different realm patients. I would say that treatments like 6-month braces and 6-month smiles are probably more for more advanced crowding cases, simple as that. So if you have more crowding, large canine movements, then actually those sorts of treatments are probably more suitable. The Inman Aligner is definitely more for incisor movements and mild canine movements, and also typically for patients who have, hygiene issues because of their minimal crowding. They don't want to have brackets on their teeth. So it's just, as I say, it's an alternative option. I mean, the truth is, I think every dentist needs to offer as many options as possible. And the difference with what we're doing, as I say, is we have this common thread of diagnosis and assessment that starts with Inman Aligner, digital space evaluation, forum support. So all the doctors know when they move from it, that when they start with Inman, then go to clears, then go to the fixed braces, everything is done in the same way and they're dealing with the same people.
Okay, you were saying...
I think those other systems are great, though.
Okay, but you were comparing 6-1 smiles and Power Prox 6-1 smiles to more movement than an Inman Aligner. You're saying more mild movement. But what about those versus clear aligners? So is clear aligners more movement than the Inman Aligner?
Not hugely. Yeah, maybe, yes. You probably can move canines a little bit more and maybe first premolar a little bit. But there may be more often cases where we will do a whole case with one arch Inman Aligner and the other arch clear aligners. And that the nice thing is that case can be planned digitally on one setup and produced by one lab, and the whole lot will come out to you and be fitted on the same day. You've seen an Inman Aligner. You wouldn't want one at the top and one at the bottom on the same mouth. There are patients who do that, but they're usually, or they're nuts. It's one of the two. But quite common will combine those treatments. So yeah, I mean, I think that clear aligners, they're way slower. They are more expensive, but there are always certain situations where they work better. And some patients just prefer them. Some patients want the speed of the Inman Aligner.
Okay, I'm wondering, one of the things that I admire and respect about you and love your message so much is, I've been a dentist for 28 years, and when you start peeling off all the enamel on the upper front 10 teeth to do veneers, I mean, that's aggressive. And those teeth, when you strip all the enamel off them, they walk out of there, it looks gorgeous. But 10 years later, 20 years later, what percent of those 10 teeth would you think had died and at that time need a root canal because you stripped all their enamel off and did veneers? I mean, and yeah, what percent of those cases would you say would die and have needed endodontic treatment?
I'm not sure what the figures are, but I know because do you know what, Howard? I did that years ago, and I did that 10, 15 years ago, and that's why I changed. And patients would come back, and you had patients with endo, you had patients with fracturing. Let me just switch that off.
Is that your girlfriend or your broker?
I have no idea, but I'm switching it off. But you had patients with fracturing veneers. You had patients who then needed a crown. And do you know what? The patients that 10, 15 years ago who I told them that it would be a good idea to have the veneers, I just feel terrible guilt now that I did it. I often do bits and pieces for them for free because I feel bad. Back then, we were using digital smile makeovers to try and to basically tell people that they needed to have this done. And I realized very quickly once I started to align teeth that actually the psychology of a patient changes as soon as they see their teeth improve their mouth. I've had, and this is a fact, I've had over 100 patients in my practice who've come to me wanting 10 veneers, who as soon as I started to align and bleach their teeth, they changed their mind completely. So I'm not a big fan of the concept of smile design because I believe that actually patients should be allowed to see their teeth improve progressively through what we call progressive smile design. So I'm not anti-veneer. I just think the veneer is, people jump straight into veneers as if it's the be-all and end-all of cosmetic dentistry. And the honest truth is that I've had so many patients who started off wanting veneers, wanted wider buccal corridors, wanted higher, longer-looking teeth. And the minute they started straightening and whitening their teeth, they didn't give two hoots about all of those things. They just want their own teeth to look more beautiful.
Well, there's no doubt about it that when a human doesn't like something, they don't pay any attention to it or take care of it. And as soon as you start making them feel better about their teeth, their brushing and flossing jumps to the roof. They start coming in for their regular cleanings. And if someone's covering their smile and hates their teeth, they're not going to brush them and floss them every morning and brush them and floss them every night and get their teeth clean every 3 to 6 months. So yeah, with humans, everything is psychological, motivational, inspiration, and the hygienists and the dentists that are sitting there making people feel bad by, Tiff, you're missing your plaque and you're not brushing and you were due 6 months ago. Yeah, just make them feel all bad and then they don't come back. And it's the coaches who motivate your kids, where the kids just want to do good because they want to make the coach proud. Those are the ones brushing and flossing in the morning, coming in and all that stuff. So yeah, beauty is everything. And the thing the thing that, dentists expect that, since we're all dentists, we all got to, say all the proper things in the country club. And I've always been the opposite of just the first to call the 4,000-pound elephant in the room. And that is, they don't strip the veneer. They don't strip the enamel off their own daughters. They send to the orthodontist and get braces and bleaching. And then since they can't do that, they strip the enamel off and do veneers. And then when dentists come along like Bob Ibsen saying, well, just put veneers over the teeth. Don't do preparation. And he called them no prep veneers. And then the dentist would say, yeah, but it thickens the tooth and makes it bulky. And I'm like, what about woman beauty is natural? Does anybody think their plastic anti-gravity boob jobs are natural? Their thick red lipstick, their eyeshadow. I mean, half of them are dressed up like a clown with anti-gravity boobs, and you're telling me you're not going to thicken their tooth a millimeter? I mean, what part of a woman looks natural? Her 4-inch heels? I mean, the whole beauty look is silly looking. So why not prepless veneers? I mean, and you know what the number one complaint of a boob job is in America? The number one complaint? It's too small. And yet the dentists are filing off 1.5 millimeters of enamel because they don't want to bulk up a tooth when they're bulking everything else. Now they're doing butt implants. And the big rage in America now is some Hollywood movie star who's, I guess, has a butt the size of she's married to Kanye West or some person like that.
Yeah, I know who you mean.
So what do you think about prepless veneers? I mean, I love your conservatism, but what do you think of prepless veneers? Because you're a high grade. I mean, you're the past president of the British Academy of Cosmetic Dentistry. Would you do a prepless veneer? Would Ross Nash do a prepless veneer, or is that a?
Yeah, I mean, I have done prepless veneers. I think there's definitely a place for them, but I think unless the dentist has the ability to actually improve the teeth with just direct bonding, why would you do a prepless veneer? And you know what? I listen. This statement, Howard. Listen to it carefully, okay? And tell me if you think this is okay. But I've heard many dentists say in lecturing, I did veneers on this patient because I'm not very good at bonding, okay? Now that statement gets said so often, but if you think about it, it's got to be one of the most immoral statements in dentistry. The answer to that question is, if you're not very good at bonding, you go and learn how to do some bloody bonding. Okay, you don't stick veneers on patients' teeth just because that's all you're good at. And there's a psychology in dentistry where I can hear someone say that in a lecture and nobody even bats an eyelid. The fact of the matter is, prepless veneers can be great, but there are so many cases that I see posted up that actually the patient just could have had some bonding and just a composite edge bonding, additive edge bonding. And the truth is, unless you actually try that in the patient's mouth, how have you actually properly consented them? How do they know what that bonding would have looked like? It's the same with ortho. Patients who don't have ortho, how do they know until they've had a little bit of ortho? So I've got nothing against prepless veneers, but I think this kind of progressive approach to smile design should be that you try everything you can, bleaching, contouring, edge bonding, to see if the patient is happy with that improvement before you start doing treatments that are irreversible. And let's face it, prepless veneers I'm sure there are people that will say they're reversible, but from my understanding, it's relatively irreversible. It's not an easy thing to remove.
So how does this dentist listening in the car learn how to do direct composite veneers?
Well, I think there's material selection. I think there are amazing guys out there that my bonding is reasonably. And most of my bonding, if anyone uses, I do with just 2 shades of composite, and I don't use or nothing, and I don't do any. But there are people out there who teach it in a very, very simple way. I mean, you have people like world famous Didier Dietsch. I think is one of the best dentists in the world, and he teaches it very simple. Didier Dietsch, his name is Didier Dietsch. He's D-I-E-R.
D-I-E-R.
And then Dietsch is spelled D-I-E-T-S-C-H. Dietche, I think.
His name is Dietche?
Didier
Dietche?
Dietche, some people say.
And where's this person practice?
He practices in Geneva. Actually,
Wow.
he runs an amazing course in Geneva. He's one person who teaches composite bonding in a very simple way. Another great guy is Corky Wilhite, your own Corky Wilhite, who I saw speak in Georgia, who also he also teaches bonding in a very simple but beautiful manner. I think he's an excellent speaker. You've also got, world famous Jason Smithson as well, who posts a hell of a lot on Dental Town.
Oh my God, he's amazing. He's got 5,000-6,000 posts. You've only got 600, dude. You gotta Jason up on those boards.
I know. I need to post up more. But you know what? I mean, Jason's a real inspiration, and he's a very good dentist. But I think the key is that with these guys, with Didier, with Corky, with Jason, and even hopefully what I show, that people should realize that bonding is not magic. The materials there now are there now to make it so much more simple than it was 5 or 10 years ago, and it can be predictable. It's not for every patient, and sometimes veneers are definitely a better solution. But I think too many cases end up with veneers, and not enough cases end up with bonding. That's my feeling.
So on your assignment, can you deliver Dietche for a podcast too?
I think I could. I know him pretty well.
That's three now. You're gonna have more time spent after our podcast than during the 1 hour podcast. So this individual driving wants to know, okay, let's not be politically correct. They want to know, what composite do you use? And I know you guys don't like to do that, but I got to throw you under a bus and ask, because they're sitting there thinking. I mean, there's probably at the IDS conference. Seriously. There were, 240 different implant companies selling a titanium implant? And how many composites are there from around the world? I mean, could you even count them? So, dude, what are you using? Come on. What are you using? You're the past president of the British Academy of Cosmetic Dentistry. This lady driving her car wants to know, what the hell are you using?
Honestly, what I'm using mostly right now is Venus Diamond from Heraeus. That's what I use.
Venus Diamond from Heraeus Kulzer.
And they also have another one called Venus Pearl as well.
Venus Diamond and Venus Pearl.
That's a great material. There's a couple of other materials that I would rate very highly. Another one that I rate very highly is Renamel from Cosmetic.
My buddy Moppert in Chicago, right across from the Wrigley. He is such a neat guy.
And also, I've been trying out some material that actually Didier is using himself, called Inspiro. It's called.
Now, is that Inspiro?
Inspiro.
Spiro. And is that a product out of Geneva, Switzerland?
Yeah. I think they're only selling. Might be wrong, but I've been trying that on a few cases. Quite a few of my Dahl cases. Do you know what Dahl means? My Dahle Principle cases. I've been using it on quite a few of those recently.
Well, tell your buddy in Geneva, Switzerland, that if they're going to sell anything in America from Switzerland, they got to call it the Matterhorn composite. They got to call it the Matterhorn composite, because all Americans, their first brush with Sweden is when they go to Disneyland and ride the Matterhorn roller coaster, named after the big mountain that you can see. And so Heraeus Kulzer, that's out of Germany. Now are all these three composites, would you say they're all the same as far as they're all a microfill? I mean, they're all microfills, not hybrids for your polishing luster?
No, I mean...
Talk us through this Venus Diamond and Venus Pearl. That was your first choice from Heraeus. Is it a microfill or a nanofill?
No,
what is it?
It's nano. It's a nanofill. It's a nano hybrid.
It's a nano hybrid. And explain that, because
we're
on 8 generations of bonding, and first there was microfill, then there was hybrid, now there's nano hybrid.
My understanding is it has strength, but it also has high polishability. The polishability is not going to be as good as a microfill, but as far as I'm concerned, it's actually good enough for most cases. What I like most about Venus Diamond is it's actually very strong in thin sections. So I mean, I'm building up thin sections because I'm just putting little edges on teeth, and I've been using it for maybe 5 or 6 years now, and my fracture rate is very, very low. So the other thing I like about nanohybrids like Venus Diamond and Inspiro is that actually the dentin shade is quite opaque, so it's very easy to actually block out the join line. So most of my cases, I don't do any beveling, which some people might think is crazy, but I don't do any beveling. I literally just stick the composite on the edge of the tooth, and I use a dentin shade to block out the light, and then the enamel shade to create the blend, what I call a reverse triangle technique. But I just trying to do it as simply as I can, and to make it affordable for my patients, and to make it look good and to last, and it does. It does. So that's what I'm using.
Well, when you said that people will think you're crazy, I just want to say for the record that the world's 2 million dentists are all crazy. So since you're a dentist, you're automatically crazy. And our 7 billion patients are crazy with a capital K. The dentists are just crazy with a small c. But and good at you for saying, I mean, God, you're so awesome. You're talking about you don't want to peel off their enamel. You want to be more conservative, and you said you want to make it more affordable. And the biggest companies in the world, like out of Europe, probably one of the biggest companies ever is IKEA, because he focused on cost. He said, let's make furniture at a lower cost. In America, it's Walmart, it's Southwest Airlines, it's Home Depot. It's people who bring down the cost always do the best. So good at you, mate, on that one. But I want to ask you, this listener is thinking, okay, well, what's the difference between Venus Diamond and Venus Pearl? You said that you kind of like to keep it just to a couple shades. Is Pearl a dent and stump shade, and Diamond an enamel shade, or what's the difference between Pearl? What's the difference between Diamond and Pearl?
The only difference between Diamond and Pearl is a little softer and easier to handle, but the shade range is exactly the same. But the reason I like Diamond is because I am building up an edge. When I put it into the correct position, there'll be no slouching. It'll just hold position, so I can take as long as I want just to get the shaping, and I know it's going to stay put. Some dentists find Diamond a little bit hard, but I find, for me, it's just perfect. Basically, I think most doctors are using Pearl, but the actual visual properties are identical.
And are a lot of these cases you're doing like direct bonding veneers on the upper maxillary 6, 8, 10 teeth at one time, or are these? Yeah. Or, are you doing a lot of those, or not really?
I do, but the thing is, probably not so much now, because once you straighten the teeth and once you whiten the teeth, you just don't need to do a veneer. You just need to do an edge. That's it. And actually, an edge is so much more simple than a veneer. So, but the key is to be able.
What do you mean by an edge?
I mean literally just adding to the tip of the tooth. So I'm not doing a veneer. I mean, maybe you call it a partial veneer. So, say for example, the tip of the tooth, we were adding maybe 2 millimeters of length. I will build that 2 millimeter tip up and only take the composite bond maybe 2 millimeters down the facial surface. So I don't take it right to the tip of the
So
neck
your
of the
crown to root ratio on that would be 1-to-1. If you're going to add 2 millimeters of edge, you only overlap 2 millimeters of teeth.
Exactly. Yeah.
Wow.
I'm not covering the whole tooth. If you look at my cases online and on Dental Town, all of those cases are pretty much just edge bonding. They're not veneers. They are just edge bonding. And the one really important thing, if you're going to do edge bonding, is that you have to polish that margin super, super hard. You've got to really polish it well. And I'll get that patient back twice, maybe 3 times to make sure that I polish that margin to infinity. If you're more comfortable, then a bevel will be fine. But I just tend not to like. I'm not a big fan of bevels, really. I just don't want to cut tooth if I don't have to.
So this person in their headphones right now is on the treadmill thinking, dude, how many years out have you seen these cases? I mean, you're adding 2 millimeters of length, 2 millimeters of bond.
Oh,
I mean, how many years?
No
how many years have you been? First of all, tell us how many years have you been a dentist?
23 years, maybe.
Okay, so how many year follow-ups have you seen on this adding an edge and they're still there?
Oh, 16.
16 years.
Easy.
And are you avoiding these if they have any grinding or bruxing, or do these people have to wear a night guard? Or
now we're into a different subject, you see, because we use this concept over here called the Dahl Principle, DAHL, and
you're kind of famous for the Dahl Principle.
Well, it actually should be called the Anderson Principle, the Anderson Dahl, because the concept was originally invented by a teacher in a UK dental hospital called Declan Anderson, but Dahl kind of pioneered the concept a little bit more. But I've been doing Dahl cases for 15, 16 years, and I've still got cases that are that old. And you know what? When I go on so many courses on occlusion, and I watch some amazing speakers speak, as amazing as their cases are, I always think one thing: these guys don't use the Dahl principle, and they need to know how to do it. And actually, it's great that somebody, I can't remember, is it Dr. Terry on Dental Town, has been posting up cases on the cosmetic dentistry, because it's the first time I've seen it on the the US doctors talking about it, because it's actually hugely used in the UK, and it's not really used much anywhere else. So yeah, a lot of my bonding started off with Dahl principle. So because I has worked, it's the confidence to then just do aesthetic edge bonding, not worry so much about it the way that maybe guys worry a lot.
Okay, we're 40 minutes down and only got 20 minutes left. So she's driving to work and she's saying, okay, what is the Dahl principle? What is this? She's a Yankee and she's never heard of this concept.
Okay, well, if you have a patient who is starting to develop anterior wear, but no posterior wear yet, so the anterior bite is starting to collapse a little bit, it's a great way of intercepting this problem and actually opening the anterior bite. And effectively what happens is you open the anterior bite, the anteriors slightly intrude, and the posteriors passively erupt into contact. Everything comes, the teeth actually, the bone comes down, everything comes together. So you don't actually make longer teeth, okay? So everything comes together. It only has certain, limitations in its usage, but it's a great way of picking up patients. Now, the real magic in this is if you combine Dahl and CR. So many dentists out there use splints. I use splints sometimes, but my splint is actually my Dahl appliance. It's the bonding that I put in the patient's mouth. It's a splint they can't take out. So I'm using Dahl appliances actually and combining with CR to basically give the patient an inbuilt splint that's opening their bite, that's actually restoring the teeth at the same time. I do. Unfortunately, I teach Inman Aligner a lot, but I actually do a lot of teaching on Dahl as well. And when I get the chance to lecture, it is quite an eye-opening subject, because a lot of restorative.
What of all this is covered on your Dental Town course? You put up a course, Rapid Anterior Orthodontics Simplified. Explain that course to the listener, and what is that going to cover?
That really is only a brief introduction to Inman Aligner, and
What year
probably
did
the
you
concept.
put that up?
I think we did that about 4 years ago, didn't we? So it's, maybe we need to do another one.
Oh,
but,
you have to. Can I get you to commit to an Inman Aligner and a Dahl course? I mean, because you lecture so much, you could do this in an hour.
I know I want to do. I've had a number of people that have asked me to do more Dahl lectures, and when am I doing my next Dahl lecture and stuff? Because I know it's a subject that so many doctors want to learn about. It's difficult. It's difficult to see because there's not enough people who have long-term case photographs and follow-ups, but I've got plenty. And I think if you do it the right way, it's very, very powerful. But some people have used it the wrong way, and then it hasn't worked. So it's just about using it the right way. But yeah, I mean, I will do. I mean, I have a lecture kind of already, like a 3-hour lecture on it already done, and I gave that at the BACD last year. And that one for the first time. And I've been thinking about maybe doing an online version to kind of help people understand how it all works. But for example, I use Dahl.
I've lectured around the world, and I know you're a legend. I'm begging. The only thing I can try to sell you on is we're coming up to 200,000 members, and the Dental Town app is exploded too. So we can definitely deliver your message to the most people. I mean, we could really get the word out, because I bet you 95% of dentists have never heard of the Dahl in the United States. Would you agree with that?
I'm sure. Yeah, I'm sure they would. And put it this way: here's an example of where Dahl is useful. When doctors have cases that the patient is biting against the upper teeth, and what do? They just give the patient an upper Essex retainer because they can't fit the wire on. So actually, what we do with Dahl is we're patient open to accommodate the. That's what we do, and using exactly the same way as it is in restorative dentistry. So, if you ever want to know how to put an upper wire on the space, well, Dahl Principle is the way to do it.
And so all the labs making the Inman aligners are making the Dahl appliance too.
No, you maybe misunderstood me there, Howard. Dahl Principle, the Dahl appliance is something that actually it's direct bonding onto the teeth. So you use the Dahl Principle and you build a Dahl appliance in a patient's mouth by actually putting the composite on their teeth. Okay, so a lab won't make technically a lab could make a Dahl stent for a doctor, but Dahl is something that I do and I teach the dentist can do freehand, completely freehand. And I've probably done in excess of 500 Dahl cases over the years. I've never had to take a single one off a patient, that never had a case ever caused any discomfort. So it's quite an interesting sort of potential treatment for many doctors.
So I guess when you use the word appliance, I immediately think of that something comes in or out with the mouse. But you're saying that you use the term that you'll build an appliance directly in the mouth with bonding.
Absolutely. And I think if anyone listening to this podcast wants to see it exactly, go on Dr. Terry's thread on the Cosmetic Dentistry Forum. Maybe you can post on it or mark it, Howard, and it'll go to the top of the pile. And on that forum, Dr. Terry's posted up a couple of great cases. I've posted up 2 or 3 cases, Dahl cases. One of them is a 15-year follow-up case. And they can then see what a Dahl appliance is in the sense of it being direct composite bonding.
And you know how to spell his last name?
Sorry,
do you know how to spell Terry's last name?
I don't know what Dr. Terry's last name is. All I know is that
he goes by Dr. Terry.
All his name, his dental town name is Doc Terry.
Yeah, and we have a member search, so you could go to member search, type in Doc Terry, and boom, and then it shows all of his posts. But yeah, I love that guy. He is an amazing man.
He's a great guy.
So I'm down to only 13 minutes. I want to ask. My next question is, how many dentists are in the? I want to switch complete subjects. How many dentists are in the UK? And right now, a lot of dentists talk about that the British had the National Health Service, the NHS, and we've been told that over the years, a lot of the number of dentists participating in that is going down, and the number of dentists that are breaking out and just going independent. Fee for service is going up. Can you kind of tell the Americans what the scene is? How many dentists are there? There's 60 million British people in the UK. How many dentists would service 60 million people?
I think we only have about 30,000 maximum. So you got 30,000 dentists.
Okay, 30,000 dentists for 60 million people. Well, tell us about what your opinion is of the NHS, the National Health Service, their dental delivery, and is that model changing for the United Kingdom over your career the last 25 years?
Yeah, absolutely. I mean, I have to say, I don't think the model has ever been a happy model in the sense that it's never stayed the same for long. When I qualified 24 years ago or 23 years ago, it was changing, and there was pilots for new ways of doing it, and it's just always changing. I think a lot of dentists just get frustrated with it because they are restricted in what they can do. Some dentists make it work very well. Some dentists provide excellent National Health Service treatments. I took the decision to leave because I couldn't do what I wanted to do, and I wasn't willing to compromise at that time. But you know what? It works for some people. We have a very, very healthy private market. One thing we don't have much, like you guys do, is we don't have much insurance. So people are either national health or they're completely private. They pay for everything. There is insurance, but I would say maybe only 5% of people have some kind of dental insurance. So it's quite a different system here, actually. The NHS, well, the truth is, Howard, I'm not allowed to criticize the NHS. I don't know if you know that, but I can't say anything bad about it. So you're not going to get anything bad out of me. We're not
because
actually,
they'll take your license away if you criticize them.
If I criticize the NHS, I could be in big trouble. So we can't. So all I'm allowed to say is that the NHS can get you to a state of oral health, and in truth, it can. And in truth, it does. There's a lot of good that comes out of the NHS. But unfortunately, dentists are not allowed to say exactly what they think about it in the UK.
Huh, that seems crazy in an ancient old democracy like United Kingdom.
It does seem a bit strange, doesn't it? But I can tell you, I've already come close to being in trouble once by being misquoted in a newspaper. So I don't want to get there again.
Huh. So
I got
so let me ask you this. So then, what percent of the dentists are not in the NHS and would be cash only patients? I mean, is that like 1%, 2%, 10%?
No, we have about I think we have about 20% are completely 20% are private, maybe 10% are completely. So I think there's about maybe 25% who are mixed. They have private and NHS.
So 1 in 5 dentists have a cash practice.
Yeah.
And how is that? So of your practice, what percent of your patients just write a check or give you a credit
Everybody.
card? Yeah.
Everybody writes a check or credit card.
And it's so funny how people don't realize, they're born into their language. My 2 older sisters are Catholic nuns, and they have no belief that if they were been born in Saudi Arabia, they'd be Muslim, or if they had been born in India, they'd be Hindu. And it's so funny because when you go to Brazil and China, there's no dental insurance, and the industry is perfectly fine. In America, these Americans, they take care of their house in cash, their car in cash, their entertainment in cash, and they walk in a dental office. Both the patient and the dentist believes that the employer is the one responsible for this bill, and they spend all their time trying to get the employer's insurance to pay, and it's ridiculous. It's literally ridiculous. I mean, they pull up to your dental office in a $30,000 car. It's kind of like the joke of where this is actually a true story. Someone just told me today that someone was locked out of their car and they didn't have the clicker wasn't working, the battery went dead or whatever, and it didn't even dawn on them that they could stick the key in the car door and just unlock the car. And it makes me so yeah. The Americans need to hear this, that when you go to China and Brazil and Russia and India, people just get out their credit card and they pay for dentistry. And
they do. They do here. I mean, obviously, the health service is paying, and even the health service doesn't pay everything. It only pays a certain amount. The patient still has to pay a fee. And you know what? I mean, the National Health Service is a funny thing. It's difficult to understand if you're from the US. Dental service, I think it needs a lot of help. It's got a long way to go to be a good working model. I think the medical health service in certain areas is just unbelievably world class. In some areas, not so good. But I think we're very lucky to have that system here where our health delivery is free. I mean, it's a good thing to have, I think.
I think the future of politics for at least the next 1,000 years is going to be the same game everywhere. It's like none of the people want to pay taxes and they want to get everything for free. So just game theory. But at the end of the day, you're going to have to buy your house, your car, your gas, your food, your dental. Hey, I want to ask you, I hope this doesn't come off rude or personal being an American and you're British, but I have to ask this, but how come in culture and comedy or whatever, people always make fun of British teeth? My favorite cartoon is Family Guy. Do they have Family Guy in the UK?
Yep.
And whenever the British guy comes over, he's got 25 gnarly teeth. They're all going the wrong way. I swear to God, I don't know if it's just the jokes in America. I don't know if this is true in Europe, but in America, British are associated with crowded bad teeth. Are you aware of that stereotype?
Yeah, we're definitely aware of that. I've seen the Simpsons Book of Smiles. It's well known. I think people are aware of it.
But do other countries make fun of British, like the Germans and Russians and Japanese and Polish, or is this just an American thing?
It's an American thing. Believe me. Have you been to Japan? Have you been to France? Have a look around there. I mean, the French don't only have French people. We think French people have bad teeth. Okay, over here. So that stereotype is just an American stereotype. it is an American one. I think, yeah, I think
And
it
where
is
do
an
you think
American
that
one. And I
stems
think
from? Where do you think it stems from? Because British was our mother country, or what?
Probably because in the 80s and 90s, everybody that you saw on TV and all the actors and all these guys all had crooked teeth. And, the guy from Top Gear, look at his teeth. You know what? It's just, it's there. But it's changing quite a bit now. I think people are becoming much more conscious about their teeth. And Great Britain has the biggest market in private dentistry and cosmetic dentistry in Europe, easily. Everyone knows that. So, and that's with a only 25% private health market. So it's changing a lot.
I think you and I need to write a joint letter to Seth MacFarlane and tell him that the British has the highest market of private pay and cosmetic dentistry, and Family Guy needs to rewrite the British guy. Remember, it was
They do, and also you can tell him that Great Britain's got a lot of good speakers as well. We've got a lot of good teachers. So no, I'm not just talking about. I'm talking about people like Jason and people. There's a lot of great guys coming from the UK now. So
and Jason is a legend on Dental Town. I think his thread it has tens of thousands of views. The Jason Smithson disciple thread. I mean, he has his own disciples around the world. He's a big fan of Buddy Moppert's Cosmodent in Chicago. He really likes the Renamel, right?
Yeah,
and that was one of your choices.
I think Jason, he can use it. Jason uses all sorts of material. Actually,
and you also mentioned another one, Inspire, and you'll deliver that guy on a podcast, and he can tell us about Inspiro from Geneva, and by the end of the podcast, I'll have it changed to the Matterhorn. I want to ask you one more very sensitive question. I hope this doesn't offend you, but as an American, Lady Di was a legend. In fact, when she died, it was front page news for a year. And when my hero, when I was little, grown up Catholic, was Mother Teresa Calcutta. When she died, it was about the same time period they both died. And I swear to God, Mother Teresa was like on page 6, and Lady Di was front. It looked like she had 4 bicuspid extraction. It looked like she had a narrowed arch. I've never seen her dental records or models, but you're a Brit. Did she have 4 bicuspid extraction, or what was your assessment of her cosmetic work?
I would expect Lady Di. I would expect that she probably did. There was a time when that was very common over here, and again,
I mean, did you ever have those thoughts when you were looking at her that she was a 4 by extraction?
I think when I at that age, I probably wasn't even doing dentistry, to be quite honest with you. I probably didn't really occur to me, when she was around and when she was famous and stuff. I think I was doing dentistry, obviously, but yeah, I think I did think that. But yeah, she definitely had quite a recess, and it's quite a common thing. You see it. That kind of post-extraction look, it's quite common, but certainly this is changing quite a bit. Not a lot more orthodontists are doing non-extraction based work over here now. So I think you're going to start to see a lot more Brits looking like Americans soon.
My God, the orthodontists actually forced the general dentist into ortho back when I got to school in '87. I mean, the orthodontist sent him back, this person with like literally spacing on almost all the teeth, and tell you to pull the first 4 buys. And you would just look at this like, what the hell? I mean, it was just crazy. And then some of the 4 by, and you're right, it's the 4 by plummeted. In my backyard, it's probably not even 1 in 4 cases. And then the other thing that I've still cringe on in 2015 is how they'll want 4 buys removed because they need to pick up 3 or 4 millimeters, and all these teeth have MODs in them. It's like, dude, you could replace all these MODs that are all old and ugly, and you could replace them all and just have open contacts and have your space right there. You know what I mean? So, or they'll have big over-contoured crowns on their first molar. And it's like, do you not realize that restoratively we could almost get all this space? So I only got you for a minute and a half. So I want you to go into your minute and a half big close on why, when this little lady gets to work, she should log on to iasortho.com and learn how to do her Inman Aligner. And you're going to tell her all day today what case should she be looking for. She's going to see 8 patients on hygiene. She's got patients in her mind all month. What would be the low-hanging fruit cherry pick case for me to do my first case with? What would this be? Would it be a man, a woman? What class 1? What's cherry pick me a case?
It could be man or woman. You know what it is? It's a patient who has got mild and moderate crowding. But what you need to tell that patient that they don't realize is that crowding is going to get worse, because the studies, the evidence shows anybody with mild and moderate crowding, their teeth are going to get worse. Their canine width could potentially collapse. Their guidance could change. Their perio could get worse. The staining will get worse. The edges of their teeth are going to differentially wear. They're going to absorb color. I think as dentists, we don't think of the long term so much. The minute you start to tell your patients this, and you can show them photographs, and you can watch taking photographs of patients' teeth for 15 years, and patients are treated, their teeth move, their teeth age. And what we do is to anti-age teeth. We're trying to stop teeth from aging. So if you go in, you align teeth, you fix, retain them, you can actually keep the teeth not just looking better, but functionally better for a longer period of time. When I started doing ortho for cosmetic reasons, I didn't realize that actually straightening and fixing that canine width was actually going to provide a huge functional benefit. That's where this is all going long term. I hate the word cosmetic ortho. Actually, what we're doing is interceptive restorative ortho. That's actually what we're doing.
And if she logs on to iasortho.com, you have online CE there to teach me how to do these intro Inman Aligner cases.
Yeah, we do.
And how many hours is that? And how much money is that to learn the basics of Inman?
The Inman Aligner online CE is about $299, but there is a brand new super duper version coming out very soon. So I would say hold off for maybe a couple of months or a month or so. We have a brand new version coming out, which I've just finished recording now. The clear aligner is about two hours. The Inman's will be about 4 hours or 3 hours. And then the clear aligner course is around about 2 hours of CE. But then the key is it's a course, but what you really learn is by using these forums. We have thousands of users on these forums, and we have about 6,000 cases on one forum alone. And they're just a massive learning resource for so many dentists. That's really the key.
That is awesome. And when can we expect new courses from you on Dental Town?
I'm working on it, and I think I'm going to do an updated kind of Inman Aligner and clear aligner type course and progressive smile design type course. And I'm going to definitely work on a Dahl Principle course, because I think there's the need for that, I think, is just huge. I think every dentist in the world could benefit from understanding the Dahl Principle. So I want to do a little bit of an intro lecture on that, and maybe develop some courses beyond that long term.
Well, Tif Qureshi, you are an amazing man. I've heard about you from dentists in countries. I've lectured all around. I was so excited when you accepted my offer to come on today. And I just want to thank you for all that you do for Dental Town, all that you do for dentistry. And, dude, I just think you're a rock star. Thank you so much for coming on my podcast.
Thanks very much for having me. I wish you'd told me that I was going to be on video, and I would have had a shave and put a shirt on. But anyway, you see me as you see me now. Thanks very much for having me.
I'm going to send an email off to Seth MacFarlane now and tell him those new stats that the British have the biggest cosmetic dentistry part. But hey, dude, thank you so much for your time. And God, in the internet, great. Here I am in Phoenix talking to you in the UK.
It's amazing.
All right, buddy. I'll see you on the boards. Bye-bye.
Take care.